Today I am going to talk about the common pediatric surgical conditions in office practice. So this is Advanced Pediatric Center at PGI Chandigarh, where I worked for nearly 40 years. After that I joined MMISR Bathinda. Now I am going to discuss about the common surgical problems. They can be divided into below the belt and above the belt level. Below the belt level, the more commoner problems are urological problems, hernias, undescended testes, rectal bleed, constipation, and rarely anorectal malformation, though they may be also common in neonatal age group. Above the belt, tongue tie, cleft disorders, bronchial defects, lymphovascular defects, umbilical defects, and then esophageal atresia with tracheal fistula and hepatobiliary problems. The hydronephrosis can be diagnosed in antenatal period, and this is now becoming the more common problem in all the neonates. And we say that there is a hydronephrosis in antenatal period when the antero-posterior diameter of the renal pelvis is more than 4 mm in second trimester and more than 7 mm in the third trimester. So depending on this, it can be mild, moderate, severe. We label it as severe hydronephrosis when the epidiameter is more than 10 mm in second trimester and more than 15 mm in third trimester. In antenatal period, we advise ultrasound at 16 to 20 weeks to evaluate for lower urinary tract obstruction and renal dysplasia and extra-renal structural malformations. This is the algorithm how we are going to treat the hydronephrosis depending upon whether this is unilateral, bilateral, or associated with systemic malformations. So coming to the postnatal evaluation in hydronephrosis, this is again the detailed algorithm I am not going to discuss, otherwise it will take a long time. But usually I can say only one thing: in about 60% of the cases, the hydronephrosis which diagnosed in the antenatal period, it resolves spontaneously. So only 30 to 40% of these babies require surgical intervention later in the life when we go on following these with serial ultrasound and nuclear scans, EC scans. So now coming to the problems below the belt problems, inguinal hernia being the most common anomaly seen in our neonates and children, and this is more common in premature infants, and it is because of the failure of the closure of the processus vaginalis completely during the fetal and newborn development. Usually it remains asymptomatic, seen either by the mother while bathing or the physician when examining the child. But this is once you diagnose hernia in a baby, we advise surgery at the earliest, in contrast to the hydrocele. In hydrocele you can wait till 1 year of age and then after that you can decide. But in hernia you have to operate early because of the problem of incarcerated hernia. What happens? The bowel comes through that ring and then it gets entrapped, and then edema develops and then vascular supply gets compromised and then intestine may become gangrenous. So this is the real emergency. We have to go in and resect the gangrenous bowel, and so we advise parents to get hernia operated as early as possible. Previously there was a saying that if the child is less than 6 months of age, if it is a female baby, or if hernia is on the left side, then you have to get the contralateral expression of the opposite side. But we are not following that principle because we think that incidence is very less, and this may be the policy led by the American College of Pediatric Surgeons because of their money earning habit and getting money from the insurance companies. That's why they have started this business, but we are not following in India this practice at all. This is the operative photograph of baby with hydrocele, you can see the fluid filled sac. Now coming to other problem in these babies, undescended testis, where on examination you may not feel testis in the root of the scrotum. So what happens, this is the diagram showing that it may arrest at the site of in the abdomen, because it descends from the renal fossa to the inguinal region and to the scrotum. So it may get arrested at any point. So it can be intra-abdominal, it can be canalicular, it can be inguinal, or in the superficial inguinal pouch. But this undescended testis may be found at the ectopic sites also. Apart from this routine, this migration route, it can be pubopenic, femoral, in perineal, in transectopia on the other side of the scrotum. So that is known as ectopic testis. The most important thing is differentiate between the retractile testis and undescended testis. Retractile testis doesn't require any surgical intervention at any time, maybe after 12 to 13 years of age, because we think that by the 12 to 13 years of age, the retractile testis will descend. If it does not descend, then we go for surgery. So how we can differentiate? Retractile testis can be brought fully to the bottom of the scrotum without difficulty, and it stays there. And usually if you take history from the mother or parents, they say that testes reside spontaneously in the scrotum some of the time. And it requires routine examination at birth, and depending upon, we usually operate these undescended testes at 6 to 9 months of age, because if we leave these testes more in the abdominal position or apart from this inguinal, because God has made this scrotum to balance so that it may not be exposed to the higher temperature. So we don't want to leave it for longer time, because then spermatogenesis will get affected. So we operate at 6 to 9 months of age. Other condition is hypospadias. Hypospadias, where there is a child passing urine from the under surface of the penis. So urinary stream will not go straight, it will curve towards the inner side. And it may be associated with cordy. So these are the various positions showing that it may be glandular, it may be subcoronal, it may be distal penile, mid penile, proximal penile, then pinoscrotal, then scrotal, then perineal. So this is one of the photograph of this hooded prepuce and then cordy, it was stretched. So this is the other common condition, is this hypospadias. But in hypospadias, if it is a pinoscrotal perineal, then one has to rule out the other conditions also. It may be associated with intersex also. So you have to get genetic analysis, you have to do for ultrasound examination, you have to go for cystoscopy. And the best time for hypospadias repair is 6 to 18 months. But what we tell the parents, because hypospadia usually present with the cordy. Cordy means penis is slightly curved this. So we tell that we will correct the cordy first, then hypospadias we will do urethroplasty. And the third stage, we always tell parents that there will be fistula, urethrocuteal fistula. We have to close the fistula. So these three stages we have to explain, because the most legal complication happens when you don't explain that there may be chances of fistula formation. And in pediatric surgeons, there was Dr. Ashopa from Agra. In his hands, the results was very good. The fistula rate was less than 1%. Otherwise, in India, nobody claimed such a best results in hypospadias surgery. Other condition is phimosis, that every pediatrician, everybody will see phimosis in the newborn period at 1 month or 2 months. If it is physiological, usually it's physiological, so what we say, mother or father, to just you clean the prepuce every day and then apply topical corticosteroid, that is a 0.1% mometazone cream twice a day for maybe 2 to 3 months, and in 90 to 95% of the cases, it start retracting. So there is no need of any surgical intervention in these cases. However, if there is a scarring at the tip of the prepuce or because of there is difficulty in detecting even after 3 months of topical steroid application, then one has to go for circumcision. Other acute emergency in babies are acute scrotum. There children may present with torsion of the testis, where you can see the gangrenous testis and there is torsion, twisting of the spermatic cord is there. So this has to be clearly differentiated from the epididymoarthritis, and one has to get Doppler ultrasound. If it shows that there is a good vascular supply, that means there is no torsion of testis. It may be because of epididymoarthritis. But if there is no vascular supply, that means there is a torsion of the testis and there are chances of gangrene. So this is a surgical emergency. We have to operate within 3 to 4 hours. Other conditions, rectal bleed. The most common cause of rectal bleed is fissure in ano, then intersusception, rectal polyp, and in slightly bigger children around 1 year of age, there may be one term midgut volvulus associated with malrotation. Other common condition in children are constipation. This is usually we say then when the child is not passing stool every alternate day or every day and passing only with laxative, then we say this is a child may be suffering from constipation. Then we have to take careful history. And then in red flags on history is when the constipation start within first few weeks, or there is history of delayed passage of meconium. This is most important. One has to ask the parents when the child passes the first meconium. If more than 40 years, that means it was delayed passage. In bigger children, failure to thrive, bladder dysfunction, and if there is no response to conventional therapy, lot of fluids and high fiber diet, and there is no response, then also we label it as constipation. And what are the red flags on examination? If there is abdominal distension, pilonidal sinus, patulous anus, empty rectum, and most important, gush of liquid stool and air from rectum after finger withdrawal, that is known as blast sign. That means child may be suffering from Hirschsprung disease. So this is algorithm to how to treat the constipation, but usually in first we treat with conservative treatment. We advise parents to give lot of oral fluids, high fiber diets, and then add some laxative like lactulose and all those things, and then we see. But the most important thing in these cases, we have to tell the parents for the toilet training. What we have seen, that child is not toilet trained. वो जब उठा स्कूल चला गया, जल्दी जल्दी से मदर ने तैयार किया, चला गया, शाम को आया, फिर शाम को गया नहीं तो ऐसे. So that will lead to constipation in these children. So we have to tell the parents that you have to tell the child to go to the bathroom morning when he woke up before going to school. We have to break that cycle. Whenever he wants, he will go to toilet. That is not the thing. This is the one press report. When in 2002, I have done this single stage transanal endoductal pull through procedure for Hirschsprung disease in a 21 days old child, and I was the first one in northern India to develop this technique, though it was developed, but already I have applied in PGI. Now, I will see if his video will work. Yeah, this is the thing, because in single stage we operate through the anal route only. So this is, I am operating through anal route, I am giving incision, and then mucosa all around is separated. And then submuscular plane, we pull the bowel outside through the transanal route. But in this case, the frozen section biopsy is very important. If this facility is not available, then we are not able to do surgery. And this is indicated in selected cases, means short segment Hirschsprung disease, when the aganglionic segment is not very short, very long. It should not be beyond the rectosigmoid level. So this video was made in PGI. Now you can see this, I am pulling this in submuscular plane, submucosal plane. See, this whole bowel is, means about 10 centimeter bowel is taken out. Now after cutting the rectal cuff, I am taking one stitch just to so that it will not get disoriented, 12 o'clock position. Then send the 3 biopsy. I am taking full thickness biopsy and sending to the pathologist for fusion section examination. So once they say at this level there is ganglion cell, I will cut that bowel and then I will do the coloanal anastomosis. So this is done all through transanal route. There will not be any abdominal incision, no scar, nothing, and child can be discharged on the 3rd postoperative day. So this is the newer technique in Hirschsprung disease. Worldwide, everybody, even in India, all are operating through the same procedure. So other condition is anorectal malformation. The baby may present with absence of anal opening, and here one can see this is a pearl sign where meconium pearl is seen at the site. So this may be low ARM because we decide this on the basis of X-ray, cross-pointable lateral, and if it is a high intermediate ARM, we have to go for colostomy first, then go for definitive surgery. Definitive surgery is described by Alberto Pina, that is a posterior sagittal anorectoplasty. So this should be done in 2 stages. But in this case, what figure is there? This is low ARM. It has to be done through anoplasty. So it can be done in local, and this is simple procedure. This is again in the management in male ARM is different, female ARM is different. Now coming to the above the belt problems, tongue tie. Tongue tie is also very common, though remains asymptomatic, and it does not cause, we say that there may be problem with articulation, so we usually advise to get it done around 1 year of age. We do it frenulotomy. Now cleft lip, cleft palate, they also present. Cleft lip is operated within 6 months, but cleft lip may be after 18 months of age. Branchial cleft, sinus cleft are there. First branchial cleft, second branchial cleft, third branchial cleft. They all requires excision of the sinus, branchial fistula or sinus. There may be lymphovascular defects, hemangiomas, so they require. In hemangioma, lately the recent treatment is we give propanol, oral propanol. Previously we were injecting this hydrocortisone, but now we are not injecting it. The result is much better with oral propanol. So this is the newer technique in management of hemangiomas. Now coming to umbilical defects. There may be umbilical hernia, but in umbilical hernia we usually tell parents to wait till 3 years of age, and by that time that defect gets closed automatically. We don't advise any coin application and then strapping, nothing like that, because that may cause incarceration of the bowel through umbilical defect. So we advise reassurance and observation. There may be umbilical granulomas, you can see here. So for that, though literature says you apply silver nitrate, but in PGI we have started applying common salt over this granuloma, and result is very good, though it has not been published yet, or in some papers there, but result is very good. So there is no need to search for silver nitrate, common salt found at home. You tell the parents to apply, and in 2 to 3 weeks it always disappears. There may be hernia of the umbilical cord, that is other. Apart from umbilical hernia of the cord requires surgery. And if there is a supraumbilical hernia, not through that umbilical defect at the above, that also requires operation whenever you diagnose. You don't have to wait for 3 years. So hernia of the umbilical cord, supraumbilical hernia, they require surgery when you diagnose it. There may be patent omphallomesenteric duct. So what happens sometimes, you ask mother what is coming through that umbilical, they say some fecal-like matter, some urine-like. So if fecal matter is there, that means there is a patent omphallomesenteric duct is there. And if there is a urine is coming out, that means there may be patent urachus, so it may be communicating with the bladder. So that both conditions require surgical intervention. Now coming to esophageal atresia and tracheal fistula. This is very common condition. In 2024, here in AIIMS Bathinda, most of those who may be from AIIMS here, but from Bathinda, I have operated one low birth weight baby, 1.3 kg case of esophageal atresia with tracheal fistula from Barnala. Now child is more than 1.5 years old, maybe 5.5 kg and something like that. Child is now taking milk, everything through oral route. But here I want to confess that my operated babies of esophageal atresia with tracheal fistula. One is MBBS doctor from IGMC Shimla, and she has gone to US for further studies. Second one is from Rishikesh, male child, son of a teacher. He is now computer engineer working in multinational company in Delhi. And one girl from Manali, I operated in 1990. She is a physiotherapist working in Delhi. And one from Bihar. That baby was brought because good family, so they brought through by plane to PGI. Then I operated that. Then on 7th day they went back. Luckily no complication, but otherwise there are complications in esophageal atresia also. And most common complication being the anastomotic leak. What we anastomose, that may leak, then we have to keep it for longer time. So here in AIIMS Bathinda, that child is doing well. I am not able to start the neonatal surgical ICU here for outborn babies. So what babies are born in AIIMS Bathinda, we operate it. But from outside, what babies are born, they don't take it, so we have to refer it to outside. But it may be started within maybe 1 or 2 months. So these are the different types of esophageal atresia you can see. Here the C, type C is 85%, where there is a esophageal atresia and the distal pouch is connected to the trachea. This is the most common variety. This is the picture taken maybe 25 years back in our neonatal surgical ICU in PGI, where there were 18 tracheal fistula babies at a time. This is the picture. Nowhere in the world anybody has witnessed such a large number of babies at a given time. And when any MCH student pass from our pediatric surgery PGI, he will at least do 50 independent tracheal fistula surgery himself. So much of rush of this baby. I don't know why this incident so high in northern India, I don't know. When you go to South India, they don't get this one. And now coming to the other condition, choledochal cyst. This is the different type of choledochal cyst. This is the whenever there is a dilatation of the common bile duct. But in choledochal cyst means treatment is surgical intervention. That's all, nothing. Excision of the cyst and then hepatico-jejunal-anastomosis. So hepatic duct is anastomosed to the loop of jejunum. That is major operation, maybe 3-4 hours operation. Other one is this is EHBA. EHBA extrahepatic biliary atresia. The child may born with jaundice, means born and then develop jaundice within 2 weeks. So here one has to, if it is diagnosed as EHBA, one has to operate within 2 months of life for the better results. Otherwise, about maybe 1/3 of these babies undergo liver transplantation in future. Now this may be the last slide, because I want to tell everyone that when to refer the patient to the pediatric surgeon. If there is any antenatally diagnosed congenital anomalies, one has to refer it immediately. If it is diagnosed as hernia, it should be referred as soon as detected. Undescended testes, refer it to by 3 to 6 months so that surgeon can operate by 6 to 9 months. Aortic malformation, tracheal fistula, they should be referred immediately after birth so that it can be operated within time. Cleft lip, 3 months, cleft palate, 6 to 12 months of age. Usually one has to refer for early surgery. Tongue tie around 1 to 2 years. Bronchial cleft are operated about 1 year of age. Thank you very much for your patience hearing of it.